Hello, I'm going to talk about the chapter on gas and bloating. So, gas and bloating is a common problem that saw in gastroenterology clinic, and also can see it in the hospital as well, but mostly in the clinic. The usual causes that I saw having to do with this were lactose intolerance and gastroparesis, and also medications like metformin in particular. But as usual, it's important to go through the details of what the patient is talking about. Is it just that their abdomen is swelling up, or are they having a lot of gas passing per rectum or belching and so forth? So when I saw patients like this, of course I would do a regular examination, but if nothing showed up much as far as that's concerned, and there wasn't any significant weight loss or other symptoms, I might start with breath testing for lactose intolerance, do some breath testing for fructose intolerance, and also for bacterial overgrowth. Look at the medications the patient is on. In some cases, I might order imaging, such as CAT scanning or ultrasound, or perhaps the patient may need to have a transvaginal ultrasound looking at the ovaries. So other causes can be bowel obstruction, large hernias, cancer in the abdomen, particularly ovarian, which can be a kind of a sneaky thing. You don't want to miss that. There's patients that are on a high fiber type diet that may be causing excessive gas. If they're having a lot of belching, it may be from acid reflux or other causes. So, in addition to that, if the patient had upper abdominal symptoms, discomfort, belching, so forth, I would tend to do upper endoscopy. And if they've had a change in bowel habit, or if they're in a colon screening age, you combine that with a colonoscopy. So the evaluation can be fairly extensive, but I think that's why they're seeing me in the office, because they've already talked to their primary, or they've been to the emergency room. A lot of times they're shrugged off or told they just need to have a good bowel movement. In the emergency room, they would do like a plain x-ray of the abdomen and declare that there's a lot of stool and you just need to have a good bowel movement, you'll be fine. But that is shortchanging the patient, and you may be overlooking some very significant problems that are going on. So I don't recommend that approach. That would be unlikely to be successful. You also have to consider the possibility of celiac sprue. If you're going to do an upper endoscopy, you can do small intestinal biopsies while you're there through the scope, or you can do some blood tests for celiac sprue. Some patients have been on a gluten-free diet, and I discussed that in the celiac sprue chapter. If they're on that diet and they've had relief, then they'll need to be looked into whether they have celiac sprue or just gluten intolerance. A lot of times they've been put on a FODMAPs diet. They've been called irritable bowel syndrome. That's a very difficult diet to follow, and the question comes up, are you overlooking something there? Most patients, I think, would have a very hard time staying on that diet long term. In the chapter on gas and bloating, I have a handout of things that may be helpful. Simple things like chew your food thoroughly, eat slowly and leisurely, avoid gaseous vegetables such as navy beans, lima beans, broccoli, so forth. So there are some there are handouts and instructions having to do with that. In terms of medications, simethicone or Gas-X can be helpful. Charcoal caps can be helpful, but may interfere with any medications the patient is on, and either have to be taken 2 hours before or 1 hour after other medications. Since gastroparesis is commonly a issue, I will ask the patient whether they fill up real easily when they eat. Do they find themselves eating small, frequent meals throughout the day because they can't tolerate much in terms of that, in terms of their diet. And a gastric emptying test can define whether they have gastroparesis or not, and that can be very helpful. And the treatment is more specific, as I previously described. In addition to that, there are probiotics that may be helpful, and also peppermint oil product called IB Guard can be helpful. That can be on the more expensive side, but still something to think about. Want to look at their medications, as I've already mentioned. Perhaps if they're on metformin, perhaps they can be on extended release metformin, and that will help. Or perhaps the medication needs to be reduced or changed out. The only way to know that sometimes is to go ahead and take them off the medicine and see how they do. And if they do better, and go back on the medicine and it's a problem, then at least you know what the issue is. Also take a timing history. When did the problem start? Was it when the metformin was increased or when it was started? And that's true of almost any medication you look at. Any symptoms the patient has had in relation to when they started the medication or when the dose was increased. And there's a lot of medications that can cause GI side effects, without a doubt. And with that, I'm going to go ahead and conclude the chapter on gas and bloating.